So today we're going to talk about some disorders of the central nervous system, primarily the central nervous system. But we're actually going to talk first about a disorder that affects the ability for someone to be mobile and for the ability for postural regulation and movement, but it's actually not a nervous system disorder. It's actually a muscular disorder. But it tends to be categorized along with some of these neurological disorders because the manifestations are so similar. Okay. So the recorded lecture that you guys are going to watch covers issues of congenital malformations or congenital defects in the development of the central nervous system. So you're going to hear about things like neural tube defects, right? And neural tube defects can affect the forebrain, right? The development of the brain, or it can be it can affect the development of the spinal cord, right? So you're going to hear about neural tube defects. You're also going to hear about congenital injuries, or not congenital injuries, prenatal or perinatal injuries that can cause things like cerebral palsy. Okay? And cerebral palsy is an actual damage to motor centers in the brain that result in abnormalities in posture, gait, and movement. Okay? Now, with muscular dystrophy, patients with muscular dystrophy and patients with cerebral palsy can share a lot of similar features, but they're very, very different conditions. Muscular dystrophy is actually a group of disorders. It's a group of disorders that are inherited, and they involve progressive derangement in large muscle groups of the body. So muscle starts to physically break down, and in all of these groups, in all of these disorders, the structural integrity of the muscle is abnormal in some way, and it causes it to start to break down. Okay. And the defects, the inherited defects, are found in a group of genes that are all required for normal muscle structure and function. Okay. Now, there's several examples. The most common form of muscular dystrophy is an X-linked disorder called Duchenne's muscular dystrophy. And because it's an X-linked disorder, it's much more common in males than females. Now, the defective gene in Duchenne's muscular dystrophy is found on the X chromosome, and it codes for a protein called dystrophin. And dystrophin is found on the cytoplasmic face of skeletal muscle, so the interior surface of the plasma membrane of skeletal muscle, and it really functions as a stabilizing structural complex. It sort of stabilizes the muscle cell. Dystrophin. Yeah, no, it's okay. So for folks with Duchenne's muscular dystrophy, the mutation in that dystrophin gene produces an abnormal dystrophin protein and results in sort of this lack of anchoring and lack of stabilization of the skeletal muscle cells. So the muscle starts to break down, and it starts to get digested by proteases in the tissue. Now this progressive is a progressive loss of muscle tissue that creates a progressive muscle weakness. So kids that are born with Duchenne's actually tend to appear completely normal at birth, okay, completely asymptomatic at birth. And what starts to happen is the postural muscles of the hips and shoulders are the first to be affected. And the first signs of muscle weakness become evident at around 2 to 3 years old. So kids around 2 to 3 years old are maybe not hitting the same kind of physical milestones that you'd be expecting them to hit. And because those postural muscles are affected, their posture tends to actually take on a stereotypical abnormality. Okay. So the main problem that occurs is, especially early on, is that you start to see this imbalance between antagonistic muscle groups. So you've got two pairs of antagonistic muscle groups, and one is they're both starting to become weak, but maybe one is weaker than the other, and so the joint is pulled in a particular direction. Okay. So things like scoliosis is very common. Right? So scoliosis is if you're looking at somebody's back, it's the curvature of their spine. So the two antagonistic muscle groups on either side of the spine are asymmetrical in their strength, so the stronger muscle group pulls the spine in that direction. So usually mobility is severely affected to the point of needing wheelchairs by around 7 to 12 years old. Smooth muscle is completely preserved, and that's an important thing to keep in mind. So smooth muscle of the bladder and bowel is preserved, so continence is preserved, normal bowel function is preserved. But of course, because of and respiratory function is normal because the diaphragm is not affected. But because mobility is changed, there are some effects on respiratory function and on bowel and bladder function just because of as a result of just immobility. Okay. The respiratory muscles of the chest are going to be affected. So while the diaphragm is fine, the respiratory muscles of the chest are going to be affected because they're skeletal muscle. So you're going to have things like ineffective or weak coughing ability, frequent respiratory infections, decreased respiratory reserve. Cardiomyopathy, unfortunately, is common, and mortality usually occurs in young adulthood as a result of either respiratory or cardiac complications. So the changes in posture that are basically a result of larger muscle groups, postural muscles that are imbalanced. So you get this sort of arching of the back. The belly sticks out because of the weakened abdominal muscles. What's also very, very common with muscular dystrophy is what we call a pseudo-hypertrophy of certain muscle groups, which means that some of these muscle groups appear extremely large, especially the calf muscle is affected that way. But it's a pseudo-hypertrophy because you would expect it to be composed of all muscle tissue, but in fact adipose tissue is replacing much of the skeletal muscle in those large groups. Now, so long-term complications include the respiratory complications, the cardiac complications, and also the muscular dystrophy can result in contractures, and contractures are basically joints that get frozen in a particular position. Contractures of the hands are pretty common, and that happens when you have an imbalance of antagonistic muscle groups, where the stronger side dominates and the joint is permanently, or the joint is pulled in a particular position. Physical therapy can minimize the development of contractures. So, for example, with a contracture of the hands, the muscle of the palms are stronger than the muscle of the back of the hand. So a constant sort of stretching the muscles of the palms is very important. Otherwise, the muscles of the palm permanently shorten, and now that contracture is sort of really permanent. Okay, so contractures are something that need constant therapy to prevent. And the other thing to keep in mind is that with muscular dystrophy, even though these kids are physically limited in terms of their mobility, their sensation is completely intact. So they can feel their bodies despite the fact that they can't move it. So that's a very frustrating position to be in. So unfortunately, with muscular dystrophy, the mortality rate is mortality usually occurs in young adulthood. So usually, like early 30s is living beyond your 30s is not very common with muscular dystrophy. Okay. So, trauma to the head can cause a variety of problems. So we are going to talk about traumatic injuries to the brain and to the central nervous system, the sort of ins and outs of that and how that manifests. And then we're going to also talk about medical problems that lead to injury to the central nervous system. But traumatic head injuries can cause both skull fractures and parenchymal injuries to the brain. So parenchymal injuries are also referred to as traumatic brain injuries. And whenever you have a traumatic brain injury, you actually have two separate injuries. And we refer to those injuries as the primary and the secondary injury. The primary injury with a trauma to the brain is the actual trauma. So a blow to the head is the primary injury. The secondary injury happens after that blow to the head, and it occurs as a result of brain swelling and the release of intracellular contents as a result of cell death. So whenever we have tissue injury, we have inflammation, right? And swelling is a part of inflammation. But when swelling occurs in the brain doesn't have the capacity or the room in which to swell. So intracranial pressure rises with brain swelling. When intracranial pressure rises, there's several problems with that. Number one is that in order to perfuse the brain, right? In order to perfuse the brain, blood pressure has to be greater than intracranial pressure. Okay? So the blood has to be pushing into the brain harder than the pressure of the brain is squeezing on the blood vessels. Does that make sense? So with a rise in intracranial pressure, you will tend to get an elevation in blood pressure. Okay. And if blood pressure can't keep up with that elevation in intracranial pressure, then brain perfusion gets compromised. Okay. So brain swelling and increased intracranial pressure can compromise brain perfusion. Okay. The second thing that is a problem is just the pressure of the brain against the cranium. It can cause more injury. So the pressure of the brain against the cranium can cause more injury. And as that brain swells and presses against the cranium, there's only one place for that pressure to be released, and that's at the base of the brain, right? Because we have that foramen, or that hole where the spinal cord exits the brain, or exits the skull. So if the pressure gets to the point where it gets relieved by that hole, we call that a brainstem herniation, and that is pretty much instant death. Okay. So that's very, very extreme, but that is the ultimate that's the ultimate complication with brain swelling. And then whenever we have a brain injury, if it causes cell death, okay, then we have the release of intracellular contents into the cerebral cavity. So that means we have the release of calcium, we have the release of sodium and potassium, we have the release of neurotransmitters. And all of those things are going to affect the excitability of the brain and can cause more injury. So the brain swelling, the release of intracellular contents affect brain function, affect brain excitability. And when excitability gets out of control in the brain, what does that look like? A seizure. Okay. So that's all secondary injury. Okay. All of that is secondary injury. So things like craniotomy it has become sort of standard practice to prevent secondary injuries. Cooling of the body in order to reduce the inflammation has become common to prevent secondary injuries. Okay, so craniotomy, actually the removal of a part of the skull. Usually that that piece of bone is placed somewhere else in the body to keep it alive and well perfused. So oftentimes in the either the abdomen or the thigh. But that just creates a portal where the brain can swell and has room, okay, and it prevents that secondary injury due to brain swelling. Okay. So in terms of clinical intervention, preventing further damage to the brain as a result of secondary injury is extremely important with TBIs. So what are the sort of variety of traumatic brain injuries that we see? Brain injuries tend to be put in two very broad categories: focal injuries and diffuse injuries. So a focal brain injury is a very spatially focused injury that includes things like contusions, which are basically bruises, and lacerations. Okay? So a focal brain injury that is penetrating is a laceration. A focal injury that's non-penetrating is a contusion. Okay? So it's affecting just one part of the brain. And so in terms of the manifestations from that primary injury, it's going to be completely dependent on the area of the brain that's affected. Okay? So if it's a motor part of the brain that you have the laceration or the contusion, then it's going to manifest as contralateral loss of motor function. Okay? So right side of motor cortex manifests on the left side. Okay? If it's an injury to a speech center, it's going to be loss of speech. Okay? So the manifestations are completely dependent on where the injury is. With diffuse brain injury, there isn't a particular part of the brain that's affected. What's happening is that the entire brain is affected. And what happens with a diffuse brain injury is you have some sort of rapid acceleration or deceleration of the brain that creates a shearing stress. So, if I look here for a moment. So the central nervous system is composed of just numerous neuronal cells. And each of these neuronal cells have a cell body, right? A place where their nucleus resides, where protein is produced, where neurotransmitters are housed and produced. And then these neuronal cells also have an extensive dendritic tree, and they have long axons, right? So the brain is a very sort of gelatinous structure, but just imagine this massive bowl of Jell-O with lots of spider webs running through it, okay? Because that's really what, I mean, it's an exaggeration, but that's really what the structure of the brain is like. So if you shake that big ball of Jell-O with lots of spider webs, you get this shearing stress where the axons or the spider webs are getting pulled. Okay? So that diffuse injury affects the axons, and in terms of in the mildest result of that is the axons can just get shocked momentarily and can lose function temporarily, right, for a few minutes or a few hours. And then they regain their function. And then in a more severe way, those axons can get physically damaged. And now information flow from one place of the brain to the other is affected. So diffuse brain injury is also sometimes referred to as diffuse axonal injury. So traumatic brain injuries, times have changed, but traumatic brain injuries have classically sort of been in the realm of motor vehicle accidents, right? So you get a otherwise healthy person, they're driving and they get into a motor vehicle accident, and one type of injury that occurs in these motor vehicle accidents is what's called a coup or counter-coup head injury, where your car is going at 50 miles an hour, you crash into something that's going at 0 miles an hour, so your body is going from 50 miles an hour to 0, right? Very, very quickly. So that means that your body stops, but your head is continuing to move at 50 miles an hour, and your brain is as well. So there is a coup, which is the initial head going forward, the acceleration, and then there's the counter coup, which is the deceleration of your head going back. And if you look at the acceleration phase, you notice that your skull is going in one direction and your brain is actually going in the other direction, because your brain is suspended in your cranium. It's attached at the top and it's suspended. So as your head moves forward, your brain actually goes back. And when your head goes back, your brain goes forward. So this type of closed head injury can result in both focal and diffuse brain injuries. The focal injuries can be contusions in the forebrain and the hindbrain, so forebrain and occipital lobe, and diffuse axonal injury from the rapid acceleration and deceleration. Okay. In recent years, so for the last 10 years, we've been engaged in multiple wars, right? So there's been, so in the last decade, traumatic brain injuries have actually come from warfare. So body armor has become extremely sophisticated. So soldiers are coming back from are surviving injuries that they would normally die from, because the body armor is protecting their vital organs. But we're seeing more and more traumatic brain injuries. So while motor vehicle accidents were the sort of standard example of traumatic brain injuries, more and more we're seeing soldiers with traumatic brain injuries and much greater variety of problems. Okay, so we're going to talk more about these focal and diffuse brain injuries, but we're also going to then talk about traumatic vascular injuries. So head traumas can bring about skull fractures, parenchymal injuries, and also injuries to the vascular tissue in the brain that can then create even more problems. Okay, so this is a picture of a contusion in the frontal lobe. So contusions can really, the brain is very delicate tissue. So contusions, these focal injuries can be extremely damaging to large portions of the brain. And as I said, that they will manifest depending on the portion of the brain that's affected. Diffuse axonal injuries on the more milder scale are referred to as concussions. So concussions can vary from extremely mild to more severe, and we grade concussions on a grade from 1 to 4, on a scale of 1 to 4. So a mild concussion, right, a very, very mild concussion, really represents a temporary axonal disturbance, right? So it's a diffuse axonal injury, but the axons just sort of get stressed out or shocked and eventually get better. So grade 1 and 2 concussions, they will manifest as these sort of subtle or moderate disturbances in attention or memory, but the person will not lose consciousness, right? They'll be a little dazed, they'll be a little confused, but they will not have lost consciousness, and they will not certainly not get progressively worse. Grade 3. A grade 3 concussion may involve a brief loss of consciousness, okay? Less than 5 minutes. But with grade 3 and 4 for that matter, the loss of consciousness is immediate. It is not delayed. Concussion does not create a delayed loss of consciousness. It happens immediately upon the injury. Okay? And if they come to within 5 minutes, this is really a grade 3 concussion. Grade 4 happens when they're out for more than 5 minutes. So grade 4 they lose consciousness immediately, and they're out for more than 5 minutes, but it's a big range, but less than 6 hours. Okay? So with grade 4, this is really referred to as a classic cerebral concussion. Okay? And what we're seeing is it's the same thing. It's an axonal disturbance. It's a temporary axonal disturbance. And the axonal injury is affecting a particular part of the brain in this kind of concussion. And it's a part of the brain referred to as the reticular activating system. So if I just, for a moment, move forward just to show you a picture of this reticular activating system. The reticular activating system is it's referring to an area of the brainstem, and it's sitting in a part of the brainstem that we call the reticular formation. It's this long inner core of the brainstem. And it's this neural network that's sitting there. And the job it has is very important. It's a relay station. The reticular activating system is a relay station. It's where all sensory information from the body comes in and is then conveyed to wherever it needs to go in the brain, in the cerebral cortex. Okay? So it's just this like communications hub. All right? So all of these all of this sensory input, both somatosensory and autonomic, they're all coming in here, and then they're getting relayed to different parts of the cerebral cortex. Now, the reason why the reticular activating system is involved in this loss of consciousness is because the amount of stimulation, this constant information flow to the cortex, we are constantly receiving tremendous amount of sensory input from the body. So the reticular activating system is providing an incredibly high level of cortical stimulation all the time. Okay. So the activity of the reticular activating system is described as determining the level of cortical arousal. Okay. So it's like your brain is a tired mom, and the reticular activating system is like a 3-year-old that's constantly talking to her. Okay. So if for some reason the 3-year-old falls asleep, right, mom might fall asleep because she doesn't have this constant stimulation of the 3-year-old talking to her. Okay? So the reticular activating system, when it temporarily goes dark with this cerebral concussion, the level of cortical arousal goes down, and that's why you lose consciousness. It's not that your brain isn't still thinking and working. It's just that all of a sudden the level of cortical arousal has gone down. Okay? And then with the return of consciousness, when the person wakes up, right, in less than 6 hours, that represents the RAS system coming back online. Okay? So we're going to talk more about levels of consciousness and more about coma and losing consciousness. But the reticular activating system is a really important component to maintaining cortical arousal and consciousness. Okay. So this immediate loss of consciousness, it's going to last longer than 5 minutes, but less than 6 hours. When someone is out for longer than 6 hours, okay, they're in a coma. Whether they wake up the next day or not, they're now in a coma. Okay? It's not a concussion anymore. Yeah.
You know when people say you hit your head and you think you have a concussion,
Yeah.
that has something to do with...
So the reason why you're not supposed to sleep is because you can't be monitored. Your level of consciousness can't be monitored when you're asleep. Because, so we're going to talk about vascular injuries, but someone can, after a traumatic injury, lose consciousness that's not immediate, right? It didn't happen immediately after. Their level of consciousness can go down later, and that suggests that there's some bleeding in the brain, and that their brain is now, the intracranial pressure is increasing. Okay? So really you want to keep them awake so that you can monitor the level of consciousness for, yeah. Okay, so let's talk about these traumatic vascular injuries, because they often happen along with these traumatic head injuries. Now, hematoma just refers to bleeding within the brain. Okay? And bleeding within the brain happens as a result of traumatic injury to blood vessels. And then the categorization of hematomas simply refers to the area within the cranium and within the brain that the bleeding occurs. So an epidural hematoma is going to happen between the skull bone itself and the dura mater. So it's going to happen between the dura and the skull. That's an epidural. A subdural hematoma is happening beneath the dura mater. So beneath the dura mater and the arachnoid mater or the pia mater. And then we can have intracranial hemorrhages where bleeding is within intracerebral blood vessels. Okay. Epidural hematomas. The most common cause of an epidural hematoma is bleeding as a result of laceration of an artery called the middle meningeal artery. And it's an artery that runs just under the skull, just under the bone. And it's located on either side, hugging sort of the parietal area of the brain. So someone hits their head, they may have an almost undetectable skull fracture, and that lacerates the middle meningeal artery. Okay, and that causes bleeding. A couple of years ago, what's that woman's name? Liam Neeson's wife, Natasha Richards. Yeah, Natasha Richardson. So they were skiing on holiday, and she fell while she was skiing. She seemed a little dazed, but then seemed fine. And then a half hour later, she passes out. And a half hour after that, she was dead. And it was because she had a laceration in the meningeal artery. It started to bleed. This epidural hematoma started to press on the brain. Intracranial pressure went up, and then she herniated. So this is why if there's a change in consciousness that is not immediate, if it happens later, that is a really bad sign, right? Immediate loss of consciousness and they wake up is not as troublesome as a loss of consciousness that isn't immediate. Mm-hmm.
Does that always happen with these, or is it some people may have or something?
It really depends on how rapidly intracranial pressure is rising. So yeah, so a rise in intracranial pressure, classic symptoms are going to be excruciating headache, projectile vomiting, right? And blood pressure is going to go up. But in the case of bleeding with an arterial bleed, the pressure could be going up so rapidly that you're not necessarily, that you might pass out before you have the headache, before you can vomit. So it really depends on how rapidly intracranial pressure rises. A subdural hematoma, this is where the bleeding is below the dura mater, usually results from, most commonly results from something that damages the set of veins that we refer to as bridging veins. And they run, if you can see, they run through the dura mater, okay? And they're draining blood from the cerebral cortex. And they're draining that blood into a very large blood vessel at the top of the skull called the central sinus, right? It's down the sagittal plane of the skull. So the brain is suspended from the top of the skull, suspended from that place, and it's physically connected to that central sinus, to that very big vein, and it's connected in part through these bridging veins. So the sorts of things that cause damage to these bridging veins are these accelerations and decelerations that strongly shake the brain within the cranium. And there are two patient populations that are especially vulnerable to this kind of tearing of the bridging veins, and that's the elderly, especially with any degree of brain atrophy, because that creates even more potential acceleration or deceleration, and very young children, because their bridging veins are more delicate. And when it comes to very young children, oftentimes what is part of diagnosing, if a child, let's say, dies and you want to rule out death as a result of child abuse or some sort of, oftentimes intracranial bleeding, either subdural hematoma or intracranial hematoma, is a diagnostic for shaking a child or causing death because of a blow to the head or something that's due to physical violence. And the result is going to be the same. Again, you're going to have bleeding within that cavity, within that space between the dura mater and the brain, elevations in intracranial pressure leading to potentially seizure or loss of consciousness. And if the pressure is not relieved, eventually it will be the cause of death. Any questions about, we're going to get back to some of these issues around especially levels of consciousness, but any questions about traumatic injuries, the types of concussions or yeah. It's just intracranial blood vessels, so whether they're veins or arteries that are actually within the brain itself. Okay. So cerebrovascular accidents, or also referred to as strokes, are it's a group of disorders that can occur that can cause either focal or global ischemia in the brain. So there's some sort of problem within a blood vessel in the brain. Usually it results of a medical problem, not a traumatic injury. Oftentimes it's a result of things like hypertension and atherosclerosis, or an embolus. And it can, as I said, it can result in either a focal ischemia, so cutting off blood to a very particular part of the brain, or it can cause global ischemia, where brain to the perfusion to the entire brain is affected. So strokes are categorized as thrombotic, embolic, hemorrhagic, and then there's another one called lacunar. And lacunar strokes are actually thrombotic strokes, but they're called lacunar strokes because of the blood vessels that they affect, the appearance, and that they tend to be very different and occur in a particular part of the brain. But in terms of cause, they are essentially a type of thrombotic stroke. Okay. So thrombotic, embolic, and lacunar strokes cause focal cerebral ischemia. They affect a particular set of vessels in the brain, or a particular vessel in the brain, and then that's going to cause ischemia to a particular part of the brain. Hemorrhagic, thrombotic, embolic, and lacunar. Hemorrhagic strokes are going to cause global ischemia, okay, because it causes bleeding within the brain, reduced perfusion to essentially the entire brain. So thrombotic strokes are a result of a thrombus that forms usually because an atherosclerotic plaque has ruptured. So thrombotic strokes are essentially caused by cardiovascular disease. Okay. They're a result of atherosclerosis. So the risk factors for thrombotic stroke are the same for coronary artery disease, for peripheral artery disease, right? For atherosclerosis, that happens in any other blood vessel. Embolic stroke occurs because of a embolus that travels to the brain and gets lodged in one of the branches, the arterial branches that perfuses the brain. Now, an embolus can be is really any foreign substance that travels in the blood, but more commonly it's going to be a clot. And embolic strokes caused by clots usually form on the left side of the heart, and they're caused by things like valve abnormalities or arrhythmias, especially things like atrial fibrillation. Okay. One of the strongest risk factors for embolic stroke, one of the strongest risk factors for embolic stroke is atrial fibrillation, unrecognized or poorly treated atrial fibrillation. Okay. So strokes are characterized by four key features. Okay. A sudden onset, so it's very, very sudden onset. Focal involvement of the central nervous system, especially in terms of thrombotic and embolic strokes. It's going to be focal involvement in the central nervous system. And the site involved is going to be very well predicted based on the nature of the symptoms. So motor changes usually suggests the areas of the motor cortex and the cerebral cortex. Speech abnormalities are going to likely be involved when places like Wernicke's area or Broca's area, these speech centers in the brain, are affected. Okay. A lack of rapid resolution. So you have some sort of neurological defect, it's very sudden onset, and it doesn't seem to be going away on its own. Okay. As opposed to a stroke, there's also what we call TIAs, or transient ischemic events. Okay. And TIAs are sort of, if you're comparing a stroke to, let's say, myocardial infarction, the TIA is like the unstable angina. Right? It's the clot that forms, maybe it's not occlusive, okay? It doesn't lead to cell death, but it's going to cause a transient symptom. Okay? So a neurological deficit that does resolve, that sudden onset but does resolve, may suggest a TIA rather than a stroke. And there's always a vascular cause in terms of stroke. So the progression in these cases are very stereotypical. So a transient, a TIA or a transient ischemic event, you're going to have this very sudden onset of the deficit, whatever it is. It could be loss of speech or loss of hearing. It could be motor deficit. It could just be that the person sort of spaces out for a brief period of time. Okay? But it very quickly resolves itself when it comes to TIA. For a complete stroke, okay, the deficit, the onset is very sudden, and the deficit persists. Okay, it doesn't resolve itself. And then in between, you can have what's called a stroke in evolution, where you have this sudden onset of a deficit, but it could actually be getting progressively worse. And that could be because the clot has ruptured and it is progressively getting larger and larger, or you're having more vessels affected. Okay? In the case of AFib, like an embolic stroke, you can have multiple strokes happening, right? You can have multiple clots getting thrown. Right? And so in that case, the severity can progress with time. It doesn't have to look that, linear, but it can progress with time. Yeah. Streptokinases, yeah. I'm not sure. It's 3 to 4 hours.
Well, you see the window. It was a firm 3 hours from the last documented period. The person woke up and was, had deficit. You couldn't give them CPA because you didn't know when the event occurred.
Right.
But then recently they've been pushing the window out a little bit further. But I don't think it's officially documented at 4 hours yet, but they're moving it.
Yeah.
We CPA up to 4.5. So the intra-arterial CPA up to about 5.5.
Right.
And up to around 6.5, they'll do thrombectomy. And after that, the more study for
Yeah.
So they'll do partial CPA.
Wow. Well, so they're pushing it back because there's a balance between benefit versus like risk. So those the streptokinases or the clot dissolving drugs, there's a risk of we actually have far more potential areas of hemorrhage in our body than we really realize, and especially when it comes to the GI tract and the brain. So we can have areas of our blood vessels where there was, let's say, a tear or a rip or something, and a clot formed, and now the blood vessel is in the process of repairing itself, right? So if you give someone, whenever you give someone a drug that dissolves clots, you run the risk of basically removing a clot that's damming a damaged vessel and causing hemorrhage. They're probably just finding that the benefit of treatment is outweighing the risk, you know. Right. Because the treatment early on, resolving that problem early on, results in better long-term outcomes. Yeah. Yes, exactly. Yeah. So the most common areas of the brain where we see strokes occur, especially embolic strokes, is a part of the brain called the circle of Willis, and it's this circular anastomosis of blood vessels at the base of the brain. But basically, for both embolic and thrombolic strokes, the manifestations are going to be completely determined by the area of vessels involved. And so these vessels or these strokes can be categorized based on sort of forebrain areas, hindbrain areas. Okay, and so you can see on this slide here we've got just branches of the cerebral circulation, arterial circulation, and the parts of the brain that they primarily perfuse. Okay, so depending on where the blockage is, it's going to affect a very particular kind of, very particular part of the brain. So if you just categorize these vessels as being anterior versus posterior, okay, so you have a anterior stroke versus a posterior stroke, you can see that the signs or symptoms are going to vary very significantly depending on whether it's anterior or posterior. So these anterior strokes are going to result in things like headache, aphasia or loss of speech, visual field defects, okay, hemi or monoparesis, and hemisensory defects. So meaning basically one-sided changes in movement and sensation. Okay. And then for the posterior, you're going to have more of this sort of loss of consciousness, more visual field defects, vertigo, right, and less of these movement or sensory defects. Okay. And it's just because of the parts of the brain that are being perfused by these different branches. Okay. Let's say one thing about the hemorrhagic strokes. Hemorrhagic strokes often occur as a result of an aneurysm that has ruptured. So a vessel defect that has created a break in a vessel and a rupture. And hemorrhagic strokes, a very significant risk factor for hemorrhagic strokes is hypertension, because a very significant risk factor for aneurysms is hypertension. Okay. And then lacunar strokes, the word lacunar refers to, the root of that word means lake in Latin or Greek, or I don't know. But it refers to the appearance of these particular CVAs. They are these microinfarcts that happen in the pons of the brainstem. And they will often happen over a period of time. They won't result in this significant manifestation of symptoms. So they can go undetected until they accumulate to the point where they affect the function of either respiratory function or cardiovascular function or some other sort of basic life-sustaining function that occurs in the pons. Okay. And when you look at it, it looks like these microinfarctions look like little lakes that have formed within the vasculature of that part of the brain. But they're basically little infarcts that occur from the rupture of plaques in the region. And hypertension is a major risk factor for the lacunar strokes. Okay. So injuries to the brain can also be from an infectious origin. So infections of the meningeal layers and the brain parenchyma itself are referred to as meningitis and meningoencephalitis. So meningitis involves just an infection of the meningeal layers, while meningoencephalitis involves the brain parenchyma itself. Rather, encephalitis refers to inflammation and infection of the brain. Meningoencephalitis refers to both, where both of it are involved. So meningitis tends to be classified in three different ways. We have what's called acute pyogenic meningitis or bacterial meningitis. And it's pyogenic refers to the appearance of spinal fluid when the fluid is tapped, that it contains, it's cloudy and it contains dead neutrophils or pus. Okay. Now, bacterial meningitis, the microorganism that causes the defect or causes the infection tends to vary depending on the age group. So in infants, it tends to be E. coli or group B strep. In the elderly, it tends to be strep pneumoniae or listeria. And in adults, young adults and adolescents, it tends to be Neisseria. So different organisms tend to cause meningitis in different age groups. Viral meningitis is sometimes referred to as aseptic meningitis, but of course it's not aseptic. It just refers to the presence of meningitis without cloudy spinal fluid. Okay. And viral meningitis, about 70% of the time, is caused by some kind of enterovirus. Okay. So it's basically a GI virus that is somehow causing the infection in the meninges. And the manifestations for meningitis, classic manifestations are headache, very severe headache, photophobia, or a real aversion to light, fever, neck stiffness, and even to the point of neck pain, especially when the neck is flexed. Okay, it's especially when the neck is flexed. Okay. And then meningoencephalitis tends to be not an acute infection, but a chronic infection, and it tends to be caused. It can be viral or bacterial, but it tends to be caused by long-term infections, systemic infections that just eventually affect the meningeal layers in the brain. So things like tuberculosis, syphilis, Lyme disease. Okay, these are chronic infections that will often invade more and more tissue beds as it progresses. So the manifestations and the complications that can occur from meningitis tend to be rooted in the inflammatory response that the body has to the infection, okay? That then affects cerebral perfusion and creates the host of manifestations. So as a result of the infection, we have this inflammatory response. Now, the inflammatory response, we know, involves the attraction of neutrophils and monocytes that turn into macrophages to the area. They release a variety of cytokines, reactive oxygen species. Okay. We have vasodilation, increased permeability. Okay. So the inflammatory response, the part of the response that causes vasodilation and increased permeability, it's going to disrupt the blood-brain barrier. It's going to increase fluid within the cerebrospinal fluid space, and it's going to cause cell swelling. Right? And all of that contributes to some cerebral edema. And you're also going to see inflammation in the vasculature, which can cause decreased cerebral perfusion and can cause cerebral ischemia. Okay. The release of the cytokines and the release of the reactive oxygen species disrupts the normal metabolism within the brain. It can cause the acidity to increase. Right? So the pH goes down. That produces more vasodilation. You get an increase in cerebral blood volume, which increases intracranial pressure. Okay. So you see that you've got lots of different factors that are compromising the blood-brain barrier. It's increasing brain swelling, increasing intracranial pressure, and potentially compromising cerebral perfusion. Okay. So if the infection is not gotten under control, especially with respect to bacterial meningitis, it can really result in cerebral herniation and death. Okay. So most patients have a rapid onset of fever, headache, lethargy, confusion. About half complain of neck stiffness and nuchal rigidity. The nuchal is the back of your neck. So you can have altered mental status in some, nausea and vomiting, that photophobia. The Koenig sign, which is sort of occurs with meningitis in some patients, and that is resistance to passive extension of the flexed leg when the patient is laying in a supine position. So the patient's sitting in the supine position, and their knee is bent, right? Their leg is flexed, and if you want to extend their leg, they will tend to resist that. For some reason, that's an uncomfortable thing for them. And then Brudzinski's sign is an involuntary flexion of the hip and knee when the examiner passively flexes the patient's neck. So you have them flex their neck, and they basically kind of clench up, okay, because they're in pain or whatever the cause is. Okay. About half of patients, they develop this rash on the extremities, petechial or pruritic rash. You have change in mental status, lethargy, confusion, especially with bacterial meningitis. And some are going to have focal neurologic signs and potentially seizures. Coma, Cushing's triad, which is bradycardia, respiratory depression, and hypertension, are signs of extremely high intracranial pressure and potentially impending herniation. Right? So when intracranial pressure gets to be very, very high, we're talking about, there's a lot that's going to happen before you get to that point. So this is like an extreme complication. So the Cushing's triad, bradycardia, respiratory depression, and hypertension. The hypertension is that elevation of blood pressure trying to overcome intracranial pressure. Okay. And then because blood pressure is getting very high, it triggers the autonomic reflex of heart rate going down. Okay. And respiratory depression is happening because you've got pressure on the brainstem already against the base of the brain, and that respiratory center is sitting at the brainstem. Okay. So when you get signs like that, that's really impending herniation is really possible. Okay. So with any form of brain injury, whether it's because of vascular injury or because of traumatic injury or infectious injury, whatever the cause, any form of brain injury can lead to an altered state of consciousness, including a complete loss of consciousness. Now, consciousness, in terms of medical definition, consciousness is really defined in very bland terms, right? It's defined in terms of a state of awareness of self, okay? An awareness of your environment, and an ability to respond to stimuli. Okay? That's consciousness. That's basically you are an awake human being. You're aware of yourself, you're aware of your environment, and you can respond to stimulation. Now, the other component to consciousness beyond just wakefulness is actual content and cognition, meaning that you're more than just awake and alert. You also have functioning of your cerebral cortex. You also have thinking going on and cognition. Okay. So there's arousal and wakefulness, this ability to be sort of like awake to your environment, and cognition and content. Now, for cognition and content, it's cerebral cortex, right? It's the function of your brain. In order for someone to have arousal and wakefulness, in addition to your cerebral cortex, you also have to have normal functioning of your reticular activating system. Okay? You also need functioning RAS. Because if RAS isn't functioning, even if your cerebral cortex continues to think and have content, you will not appear to be awake because that RAS is not is not arousing your brain yet. Okay? So the different levels of consciousness include from fully conscious, right, going downward. First we get confusion, right? Impaired ability to think clearly, to perceive, to respond and remember stimulation. So you're basically kind of disoriented. You have some confusion. Then you have delirium, right? So you can see motor restlessness, hallucination, disorientation, maybe delusion. Okay? And delirium is usually an acute onset. Right? Delirium is very different from dementia, which tends to be more chronic and persistent. Delirium is sort of an acute onset. Obtundation, which is now you have decreased alertness and psychomotor abnormality. So first we get confusion, then we get this delirium, and confusion and delirium can actually manifest someone acting out, right? So this can actually be a very active part of this progression to lower and lower levels of consciousness. Once we hit obtundation, things are starting to actually quiet down. Okay? Then we're hitting stupor, where they're conscious, but they don't have a lot of spontaneous activity. Okay? Meaning that they can be brought back when stimulated, but there's no spontaneous activity. And then coma is unarousable, unresponsive to external stimulation or internal needs. Okay? And we have the Glasgow Coma Scale to assess sort of levels of coma. But remember, this consciousness is a result of functioning of both the cerebral cortex and this reticular activating system. Okay? Without functioning of the reticular activating system, we have cognition and content going on, but but basically you're kind of cut off from your environment because you're asleep, essentially. And you don't have this reticular activating system providing that critical level of cortical stimulation. If you have cerebral cortex not functioning, but reticular activating system functioning, the person is going to seem awake, but they're not. There isn't going to be sort of sensical. There isn't going to be content or cognition. Okay, they're going to be awake, but there isn't going to be content or cognition. And when both are affected, not only is the person not awake, but there's also not content or cognition. So with the Glasgow Coma Scale, what we're really assessing with this coma scale is the level of spontaneous wakefulness in this person, okay? The level of spontaneous wakefulness or lack of it, and their ability to orient themselves to the environment. Okay? And we break it down in terms of eye responses of the eyes, verbal responses, and motor responses. And what's interesting about the Glasgow Coma Scale, among other things, is that just by showing up you get a 3, right? So a dead person gets a Glasgow Coma Scale of 3. So eye opening, do you open your eyes spontaneously as someone who is awake does? Or do you only open your eyes when spoken to? Or do you only open your eyes to painful stimulation? Okay, or do you not open your eyes at all? Verbal response, so do they give you an appropriate response that they are oriented to person, place, and time? Do they give you a verbal response but it's confused? They're disoriented to some person, place, or time? Is it completely inappropriate? Is it incomprehensible? Or is there no verbal response? And then motor response, can they obey commands? Can they localize pain? Do they withdraw from pain? Is there simply flexion to pain or extension to pain? So flexion and extension, there's actually, with injury to the brain, there are certain postures that people can take on. And there is a flexed posture, right? So either they flex to pain, meaning that they sort of curl up, right? And they can curl up in response to pain, or they can just be in a flexed position, right, without pain. Or they can sort of extend out in response to pain, or just be in sort of an extended position. Flexing to pain or being flexed is better than being extended. Okay? But basically both of those represent some pretty severe damage to the brain. Okay? But extension is much worse than flexion. So we went from concussion, which was really sort of mild, reversible brain injuries, where the person's going to wake up. And then we went from concussion to coma, so the person has lost consciousness for more than 6 hours. And then if the person doesn't wake up from a coma, really within the first, if the person doesn't really wake up very, very soon from a coma, they tend to progress into a persistent vegetative state. Okay? So a persistent vegetative state is really a loss of all cognitive function. There's no evidence of cognitive function. There's no evidence of awareness of self or surroundings, but they retain vegetative functions and reflexive functions. So they retain some spinal reflexes, they retain some basic reflexes, they continue to, their heart continues to pump, they continue to breathe. It's possible that the breathing may be somewhat ineffective and might need to be assisted, but basically they have spontaneous vegetative function. Okay? But beyond that, there's no higher order brain functioning that can be elicited. Okay? They don't seem to interact with others. They have an absence of reproducible voluntary behaviors, no language, bladder and bowel incontinence, no oral feeding. Okay? They're not consuming food by mouth, and they may have variable cranial or spinal reflexes. Okay? And really, when this happens for longer than a month, when someone's in this longer than a month, it's really considered no longer a coma, but a persistent vegetative state. Now, at this point, obviously, if they're not being orally fed, okay, they continue to live because they're being fed and not parenterally, right? Either through TPN or they have a G-tube or something like that. So they're being fed non-orally. Now, beyond a persistent vegetative state, there's also brain death, true brain death. Now, with true brain death, you really have an irreversible loss of functioning of the brain, including the brainstem. So with brain death, you have lost your vegetative function. Okay? You're not breathing on your own. And your heart continues to beat because you're getting mechanically ventilated. Okay? But there's no spontaneous respiratory activity. And there's no reflexive activity either. The EEG testing, if you put somebody on an EEG, you will see no brain activity. That's what brain death is. Okay. Now, there is a greater recognition of a level of consciousness above the persistent vegetative state. It's sometimes referred to as a minimally conscious state. And in that state, it's not so black and white. Okay? These people may have periods of the day where they seem to respond to certain individuals. They may only respond to family. They may only respond to certain caregivers. They may be somewhat limited in their expression of the interactions, but an interaction or communication of some kind can be elicited by someone in a minimally conscious state. Okay. And that's something that is between coma and persistent vegetation. Okay. Then there's something that is very, very different from coma or persistent vegetative state. It's called locked-in syndrome. And locked-in syndrome is normal functioning of the brain, but an inability to communicate or move really in almost any way. And there's just an incredible book called The Diving Bell and the Butterfly. And I don't know if you've heard, they made a movie out of it. I haven't seen the movie, but is the former editor of Elle magazine. He had a massive stroke while driving his cute sports car, and just lost the ability to communicate or move any part of his body except for one eyelid, right, that he could continue to open and close. And he developed with his communication therapist, he developed a way of communicating where they had the alphabet. He's French, so they had the French alphabet in order of how commonly the letters get used, and it corresponded to a number, and he would blink his eye the number of times he wanted to indicate a letter, and he would form words and sentences that way, and he would communicate with his therapist that way, and he wrote a book that way. And of course the book is very short. It's I think it's only about 70 pages or something, but it's basically like how he manages this existence that he is in, you know. And so it's and it's surprisingly inspiring and uplifting, which is, so it's not incredibly depressing. It's a really amazing book. Haven't seen the movie. Anybody see the movie? Was it good? Yeah. It's not an action-filled movie. Yeah. But so locked-in syndrome is something very, very different. But these are all levels of consciousness and levels of ability to interact with your surrounding. Yes. Continue. So we're going to talk about a few degenerative diseases that affect the central nervous system. And degenerative diseases are conditions that get progressively worse with time, and the mass of brain that is involved or affected increases with time. And that's very different from conditions like cerebral palsy that are what we call a static encephalopathy, where the damage is isolated and does not progress with time, does not get worse and worse. However, static encephalopathies like cerebral palsy that happen when a person is very, very young, the manifestations can change with time, right? And it can appear to get worse with time because of a maturity of the central nervous system and a progress in terms of complications that can occur. But the nature of the brain damage that caused the problem does not progress with time. Okay? But with degenerative diseases, the actual brain damage does. Okay? So it's going to get worse and worse, involve more and more of the brain. Now, we're going to talk about two categories of degenerative diseases. Diseases that affect very broadly the cerebral cortex. So it involves many, many areas, and it sort of involves all of the cerebral cortex. And those conditions, one type of those conditions include dementia syndromes. And dementia syndromes include the most common dementia syndrome, which is Alzheimer's disease. It also includes something called vascular dementia, where the dementia is actually caused by some sort of vascular disease. There's a dementia syndrome called Parkinson's disease with dementia. So this is essentially Parkinson's disease. However, it progresses to include more of the cerebral cortex and manifests as dementia. There's a condition called frontotemporal dementia, which can look very similar to Alzheimer's, but there's some key differences, and one of those differences is actually something that can be seen post-mortem with the accumulation of something called Lewy bodies in the brain, which are something you can see histologically, these dark accumulations in scattered parts of the brain. And then there are also reversible dementias. These are dementias that are caused by temporary conditions like drug exposure or drug addiction. Okay. Or it can be a complication of a particular medical condition that once the medical condition is treated, the dementia goes away. We're going to focus our attention on Alzheimer's disease and talk about that condition as sort of the stereotypical dementia syndrome. And then Parkinson's disease, we're also going to discuss. Parkinson's disease is a degenerative disorder that affects a very particular part of the brain called the basal ganglia. And the basal ganglia is an important part of the brain in regulation of motor movement. It's not where motor movement originates, but it is very important for modulating motor movements, especially purposeful movements, and movements that require a lot of precision. Okay, so talk about Parkinson's disease along with Alzheimer's. So Alzheimer's disease. Alzheimer's disease is a dementia syndrome that involves progressive degeneration of the cerebral cortex, but the cerebral cortex and actually also eventually can involve the brainstem as well. It's a brain atrophying disorder. Okay. And the initial part of the brain that is initially affected or is first affected is called the hippocampus, and that is where that is our the part of the brain essential for memory. And so a loss of recent memory is usually the first, working and memory and recent memory is usually some of the first signs of Alzheimer's disease. So the onset of Alzheimer's is usually very insidious. It's not something that's very abrupt and dramatic. It can really involve a gradual development of forgetfulness, forgetfulness of small day-to-day happenings. Okay. So in terms of short-term memory, there's something called working memory, and then there is true short-term memory. And working memory is the kind of memory that you only need for a minute or so. Okay. Working memory is the memory that allows you right now to take notes from what I'm saying. Okay. It allows you to hold on to something just long enough for you to then use it immediately. But then you forget it. So somebody tells you their phone, they tell you a phone number to dial. If I asked you for that phone number 10 minutes later, you would not remember it. Right? That's working memory. So working memory is affected, and also short-term memory. And short-term memory is the kind of memory that you need to remember to pick up your laundry that day, right, from the dry cleaners, or to pick up your daughter from daycare, or whatever it is. That's sort of these normal day-to-day things that are not something you're going to hold on to a week from now or 2 weeks from now, but you're going to hold on to for a few days. Okay, so that's short-term memory. And that is usually, that sort of more recent memory is really what is first affected with Alzheimer's disease. So it's a very insidious onset. Once that memory disorder becomes very obvious, you start to see other deficits in cerebral function. You start to see speech and writing becomes more halted. So they're speaking, and then all of a sudden there's sort of this hesitancy, or they stop talking because they can't remember what they were going to say, right? Or they're writing and they have difficulty writing because they don't remember what they meant to say. Okay. Their vocabulary starts to become restricted, and their language becomes very sort of stereotypical and very inflexible because they don't have that sort of same working memory anymore, or short-term memory in order to express themselves effectively. And then as the illness progresses, they start to forget much more important things. They start to forget how to use certain common tools. They may seem to retain sort of coordination and basic motor skills, but they start to forget things that don't really make sense. They start to forget how to use a blender, or they start to forget how to do sort of very basic things. And then eventually, really only the most habitual and automatic actions are preserved. Everything else becomes affected. Everything else is forgotten. But what they often retain is very long-term memory or longitudinal memory. So they'll remember with exquisite detail things about their childhood, or things about raising their children, or things that happened a very, very long time ago. But they won't remember things that happened last week, 2 weeks ago. It's a very frustrating thing for the person and for the people around them. So eventually, the entire brain is going to be affected. So eventually now motor movement is going to start to be affected. So their ability to be sure on their feet and normal mobility starts to change. They start to have muscle weakness, right? They may even start to have motor changes that almost look slightly Parkinsonian, where you have fine tremors or a slowness in their movements. Okay. Eventually, they'll lose the ability to stand or walk, and they'll end up with only really basic vegetative vegetative function being persistent. So when we look at the brains of people with Alzheimer's disease, we see some very characteristic physical changes. Number one, most obvious, is atrophy. So there is a progressive loss of brain mass. The actual brain shrinks with Alzheimer's disease. And that brain shrinkage is going to affect all parts of the brain, including the brainstem and basic vegetative function. But that brainstem and basic vegetative function is the last to go. So it takes a long, long time for people to die from Alzheimer's disease, and that's really sort of the tragedy of that disorder, is it robs them of everything before it actually compromises their survival. The other two things that we see physically in the brains of people with Alzheimer's disease is what we call amyloid plaques and neurofibrillary tangles. So amyloid plaques are found inside of neuronal cells, and what happens is it tends to happen within the axons of these central nervous system neurons. The amyloid protein, which is a basic structural protein, they start to accumulate and form plaques that are visible histologically. Okay, so normally these amyloid proteins are constantly being formed and constantly being broken down. There's just this normal turnover of the protein. But something has happened now in that balance of the enzymes that produce it and enzyme that breaks it down, and you start to get an accumulation of these proteins and these plaques. How these plaques affect the function of the cells is not entirely clear, but we see those plaques very clearly in the brains of people with Alzheimer's disease. And then the neurofibrillary tangles are really these distortions of axonal structure. Okay. They look like these physical tangles of axons that are caused by the production of abnormal, what are called tau proteins in the microtubules of these axons. So the amyloid plaques are an intracellular, it's found intracellularly, and the neurofibrillary tangles are found extracellularly. And both are very stereotypical of Alzheimer's. So those three physical changes are characteristic of Alzheimer's disease. It's an abnormality in the tau proteins. It's a TAU proteins that make up the microtubules, and so it ends up causing this sort of tangle of axons for reasons that are not entirely clear. So Parkinson's disease is a degenerative disorder that is focused on one particular part of the cerebral cortex called the basal ganglia. So while Alzheimer's is really affecting the entire brain and the entire central cerebral cortex, Parkinson's is particularly affecting the basal ganglia. And Parkinson's disease is actually part of a spectrum of disorder that is just described as Parkinsonian syndrome, okay? Or there's just a spectrum of disorders that fit under Parkinsonian changes in motor function. And sort of classic Parkinson's dysfunction or Parkinsonian dysfunction is something called dyskinesia, okay, and tremor. And dyskinesia is really a slowing down of motor function. Everything becomes very slow. And then the tremors are involuntary, and they can involve the head, the hands, the entire body. And they tend to get actually worse. The tremors tend to get worse when the person is attempting a purposeful movement, since purposeful, refined movements are really the job of the basal ganglia. So the basal ganglia's normal function, so over here we've got the sort of a schematic of how the basal ganglia interacts with the motor cortex and skeletal muscle, spinal cord and skeletal muscle, in order to do its job in refining motor movements. So the basal ganglia processes a motor command, right? All motor commands originate in the central, the primary motor cortex, and then the basal ganglia processes this command and basically refines that command. Okay? It removes excess stimulation to the muscle, and it makes that motor movement very refined and very smooth. Okay? And that refinement of motor movement is done through a balance of two different inputs within the basal ganglia. We have dopaminergic stimulation, and then we have acetylcholine actually providing inhibition. And these two opposing inputs balance each other out and create a smooth motor movement. With Parkinson's, or with any kind of Parkinsonian-like disorder, we have a progressive lack of dopamine in the basal ganglia. There's actually a group of neurons in the basal ganglia, in an area of the basal ganglia called the substantia nigra. And substantia nigra refers to black substance, because when you stain the basal ganglia, those dopaminergic cells sort of accumulate stain and they become very dark. So those dopaminergic cells start to become progressively deficient in dopamine. So as a result, you lose that balance of the dopamine against the acetylcholine. And that results in this loss of refinement of motor movements. Okay. And that dyskinesia, or the slowing down, really is really illustrating this dominance of the inhibitory acetylcholine on motor movements. Now, when we talk about motor movements, there's a couple of different parts of the brain that contribute to motor activity. Of course, the primary motor cortex that initiates the motor commands, the basal ganglia that really refines it, and then there's the cerebellum, that the cerebellum is extremely important in housing learned motor movements. So things that have become sort of automatic. Sometimes people refer to it as like muscle memory. It's actually not a memory in your muscle, it's a memory in your cerebellum. It's something called a motor pattern. So these motor commands or these motor movements that are just completely automatic are less affected than the purposeful ones that we want to initiate, because that is where the basal ganglia plays the very important role. Okay. So the clinical syndrome of Parkinson's includes rigidity, not dyskinesia, bradykinesia. My mistake. Bradykinesia, tremor, and postural instability. So I refer to it as dyskinesia. I feel like I've seen it referred to as dyskinesia, but it's bradykinesia. And it's a degeneration of the dopaminergic cells in that basal ganglia. So clinical presentation, resting tremors of the hands, jaws, and feet, that slowed movement or absence of movement, the akinesia. Speech difficulty, it's slowed, slurred, altered gait, there's this thing referred to as the Parkinson's shuffle. People just don't tend to remove their feet from the floor when they're walking, so their feet sort of shuffle across the floor. They also they walk slowly, obviously, but it's a really interesting particularity about Parkinsonian walking. They don't move their hands when they walk, right? So when we walk, we don't even think about it. We tend to sort of swing our arms. They don't swing their arms when they walk. They tend to be sort of very rigid. And they walk sort of on flat feet. They can have a stooped over posture, and they can have sort of very rigid joints, decreased range of motion. So Parkinson's disease can be caused by a variety of things. There's inherited forms of Parkinson's disease, but we can also have Parkinson's disease occur as a result of repeated traumatic injury. So when I grew up, I was a huge Muhammad Ali fan. Not that I'm a boxing fan, but I was a huge Muhammad Ali fan. And And Muhammad Ali is a rather famous Parkinson's patient, along, of course, with Michael J. Fox, right? But Michael J. Fox's Parkinson's is a genetic disorder that he developed actually rather young in life. And Muhammad Ali's Parkinson's is because of repeated blows to the head, right? So Muhammad Ali, in his prime,
15 times I have told the clown, look round, he's going down, and this jump ain't no different.
trash talking, quick-footed, quick-witted.
To prove that I'm great, and if you keep talking that, I'm going to tell you the fact.
So, in his prime, and then later in life, as he developed Parkinson's,
Head down.
Your person.
So you can see the slowness. Still has a sense of humor. But you can see the slowness, the sort of the tremor. It's really almost like a locked-in kind of condition. So the all of those features of Parkinson's you can really see with him. Okay. And if you've ever heard Michael J. Fox being interviewed and talking about how Parkinson's feels to him, he talks about the morning being the hardest part because the muscle stiffness and the rigidity, it's like he wakes up just completely locked in his body. So there's really a diversity in terms of the expression of the disorder and what is some people have more bradykinesia, some people have more stiffness and rigidity, but they all sort of share some of the same features. I think that it's really unclear where it comes from, and I think that there's a variety of causes, but we're discovering new autoimmune conditions all the time. And there is a significant variation in particular forms of Parkinson's, because a subset of Parkinson's patients will eventually develop dementia along with their Parkinson's, and then the rest will maintain completely normal cognitive function until, for the rest of their lives. So there is quite a diversity in the particular types of Parkinson's disorders. Okay, so the last condition that I wanted to talk about was multiple sclerosis today. Now, MS is a degenerative disorder, but the nature of MS is one of a demyelinating condition. So the myelination, which provides essential insulation to axon fibers in the central nervous system and peripheral nervous system, progressively gets attacked, and it is thought to be an autoimmune disorder where the person's immune system is attacking actually particular fatty acids that are expressed primarily in myelin tissue. As axons become demyelinated, you start to see loss of function. Okay? So action potentials are not getting to the end of the axons. Conduction is slowed. So you really start to see loss of function of that particular set of nervous tissue. And when people are imaged, you can see in the central nervous system oftentimes lesions of areas where there's a loss of myelination. So some of the features that are very typical of multiple sclerosis, and we'll talk more about this in a second, is an onset somewhere between age 15 and 50. So an onset earlier than 15 is not very common, can happen but not very common. Onset after age 50, not very common. And the most, and even though it can be anywhere between 15 and 50, somewhere in the 30s or 40s is actually a fairly common time for the MS to manifest. The majority of patients are going to have a relapses and remissions. Okay? So they're going to have times where there's a acute loss of some function followed by an almost full recovery. Okay? And for most patients, with each relapse, they will lose a little bit more function. So the recovery they won't recover to where they were before the most recent relapse. And that's how the disease will progress. So that's the majority of patients are like that. Not everybody, but often. Optic neuritis is a manifestation that some MS patients either initially present with. So optic neuritis could be an initial manifestation of the disease, or it can occur later on. And with optic neuritis, it involves the optic nerve, and it causes either blurriness or partial or complete loss of vision in one or both eyes. And that's, of course, during that relapse, and oftentimes the person either completely recovers their vision, or they mostly recover their vision and they just retain a little bit of blurriness or loss of some range of vision. Okay, so optic neuritis is a classic potential feature of multiple sclerosis. Lermite sign is a manifestation that involves, it's a very specific sort of thing, but it's a manifestation that involves extreme pain when the neck is flexed. So when the person flexes their neck, there's this feeling that there's an electric shock going down their spine. It's a very painful experience. And again, it's something that's going to happen potentially during a relapse and may completely go away with a remission. Intranuclear ophthalmoplegia. This is going to be something that is affecting oculomotor movements. So it can manifest as nystagmus, so it can manifest as sort of that shaking of the eye, or something that affects the tracking movements, of oculomotor movements. Fatigue is very common, either as a chronic manifestation or acutely during a relapse. Pain is often a common feature. Paresthesia is often a common feature, that sort of pins and needles, that slight numbness and that pins and needles. And something called Uthoff's phenomenon is something that can happen both in between relapses, so in the remission, and during the relapse. And that's a phenomenon where when the person's body temperature rises, when they are warmed, when they heat up, the symptoms get worse. So you can have someone, for example, with MS who has had a previous episode of optic neuritis, and whenever they exercise, their vision gets blurry, for example. Okay. And that's just because the conduction down nerves changes when nerves are heated. So it's a change in symptoms when the body is heated. Okay. And features that are not suggestive of multiple sclerosis is a steady progression without these acute relapses and remissions, although some patients do actually, a small percentage of patients have a steady progression. Onset before 10 or after 50. Cortical deficits like aphasia, apraxia, alexia, neglect. Rigidity or sustained dystonia, convulsions, early dementia, or deficits that develop within minutes. So this very acute onset. So early signs and symptoms, very, very common: weakness or numbness, sometimes both in one or both limbs, and that happens in about half the patients. And so sort of a classic thing is, I believe it happens more in females than males. So a classic patient or sort of characteristic patient is a woman in her 30s. She all of a sudden has what she thinks is, let's say, sciatica, where she just has sort of numbness and pins and needles and pain in one leg, and it doesn't seem to get any better. And then that relapse progresses to an inability to move that leg, maybe more extreme pain, and then she enters a remission. Okay? But upon seeking medical attention for that, she might find out that she's got MS. Okay. So all of those manifestations that I mentioned, very, very classic for an MS relapse. So the optic neuritis, pain, numbness and tingling, weakness. They can all be either initial manifestations or manifestations that happen later in a relapse. Okay. Now, the progression of the disease, there are 4 clinical types of MS, and the vast majority of patients fall into the first category. The first category being relapsing, remitting multiple sclerosis, or RRMS. So 85% of patients fall into this category. And with this group of patients, this is what I was describing before. So if we look here for a second, with RRMS, on the y-axis we've got disability or loss of function, okay, severity of symptoms, and then on the x-axis we have time. So you see the first relapse, the initial onset of the disorder, you have some very acute symptom going on. That could be optic neuritis, that could be significant gait problems, that could be significant pain, any of the manifestations that I mentioned. And then you notice that this person completely recovers, okay? A total recovery. Then they have another relapse and a total recovery. Then they have another relapse and a less than total recovery. And then with every relapse, they are losing more and more function. Okay? And that's how the disease progresses. That's 85% of the time. Okay. Oops. Another group of patients, actually, the second most common after relapsing, remitting, is something called primary progression, or primary progressive. That's about 15% of the time, a little less than 15% of the time. Now, with primary progressive, they never really experience one of these acute attacks. Okay, they never really experience one of these very severe relapses, or even the initial onset. So the initial onset can actually be somewhat mild, but the disability just steadily progresses with time. And they may experience some plateaus, they may experience some sort of accelerating symptoms, some periods of accelerating symptoms, but they never really experience that full or even partial return to normal. Okay? With every worsening symptom, that is just going to become the new norm, and it only gets worse. So those two, A and C, represent the vast majority of patients with relapsing or remitting, having, greater between 80-85% of patients. And then less common, but sometimes there, are actually just variations on relapsing or remitting and primary progressive. So there's something called secondary progressive, which just means that initially you look just like the relapsing or remitting patients, and then eventually you just turn into a progressive patient. And then with primary relapsing, it's sort of a hybrid, where you have this progression with superimposed relapses and remissions on top of it. Okay. But once function is lost, it's not recoverable. Okay? There's no cure for MS. Once that disability is there, once that function is lost, you can't recover it. Okay? So there's strategies to try to slow the progression. There are people who swear by a ketotic diet or diet modifications with MS that maintains optimal neural function. So that ketotic diet is basically like an Atkins type diet. There's a belief that they do better on that diet than other ways of eating. And I think that there's actually some evidence to suggest that a ketotic diet actually benefits. I don't remember the details, but